Welcome back to the Deep Dive. Today we are taking on a topic that is, well, it's foundational, critically important, and notoriously dense. We're talking about the surgical and systemic management of carcinoma breast. We're diving into source material that's really designed for medical students and residents, that comprehensive clinical knowledge stack. And our mission today is to pull out the absolute high-yield truth and to make sure we internalize every single critical concept. The goal is simple. Don't miss a point.
And that's a massive undertaking. It requires a lot of precision. Breast cancer management is a true multidisciplinary field. I mean, you're blending anatomy, pathology, surgery, radiation, and molecular medicine all at once.
Right.
We're not just summarizing today. We are creating a structured knowledge map, starting with the physical foundations and then building all the way up to the modern pillars of targeted therapy.
Exactly. This deep dive is your shortcut to structured, actionable knowledge. But before we even get into the technical details, the literature reminds us of this core philosophy that has to guide all these complex decisions.
That's right. It really sets the tone for every strategic choice you make as a clinician. The core belief is that, and this is a direct quote, breast cancer treatment is not just removing a tumor, it is restoring a life.
I love that. Restoring a life.
That mantra, it means precision in our diagnosis, it means thoroughness in our staging, and, compassion in our management plan.
Okay, let's unpack this entire clinical map then. And
Right.
we have to start with the essential foundation, right? The surgical anatomy. If we don't know the physical landscape, we can't operate or treat effectively.
Yeah.
So understanding the anatomical boundaries, the pathways of spread, it's non-negotiable, isn't it?
Absolutely. Surgically, you have to define the extent of the tissue you're working with.
So what are those key boundaries, the ones that clinically define the extent of the breast?
So we define it horizontally, extending from the sternal edge medially, so the middle of the chest, all the way out to the mid-axillary line laterally. That's the middle of the armpit. And then vertically, it spans roughly from the second rib down to the sixth rib. But the anatomical extension that gets missed most often, especially during an examination, and it's also the site of a vast amount of pathology, is the tail of Spence.
The axillary tail.
Yeah.
Why is that specific extension into the axilla so crucial to remember? I mean, this is a classic don't miss a point detail, right?
It is, because the tail of Spence is a wedge of glandular breast tissue that projects up and out, superiorly and laterally, and it follows the edge of the pectoralis major muscle.
Okay.
Now, given that the upper outer quadrant is the most common site for malignancy, lesions that start in the tail of Spence can be really high up in the axilla.
Right.
And if a clinician isn't thorough, they might be mistaken for, say, primary axillary lymph node involvement rather than a primary tumor extension.
Yeah.
You have to trace that tissue plane correctly.
That distinction is paramount for surgical planning. It changes everything.
Oh.
So moving inward from there, let's trace the layers from the skin down to the deepest structure.
So we move through the skin and then the subcutaneous fat to the critical glandular and ductal tissue itself. Below that, we hit the surgical planes.
The surgical planes.
The first one is the retromammary space. This is a loose layer of connective tissue, and it's often the plane of dissection during a mastectomy. It allows the breast tissue to be separated from the structures underneath.
Okay, so it creates a natural separation.
Exactly. And this space rests directly on top of the pectoral fascia, which is the covering of the pectoralis major muscle. Depending on the procedure, maintaining the integrity of this fascia can be really important.
Now we get to what is really the determinant of prognosis and staging. The lymphatic system.
The highway of spread.
The highway of spread. If you remember one thing from this anatomy section, it has to be this.
Absolutely. The lymphatic drainage is the single most important anatomical factor in determining whether the disease is localized or if it's gained systemic access.
And the primary route.
The primary route, carrying about 75% of the drainage, is to the axillary nodes.
Okay, and within the axilla, we don't just treat all nodes equally, do we? There's a surgical classification based on the pectoralis minor muscle.
Yes.
Can you break down those three axillary levels for us? This structure is absolutely essential for clinical practice.
Of course. We categorize these modes precisely by their anatomical relationship to the pectoralis minor muscle. So level I nodes are located lateral to the lateral border of the pectoralis minor. These are the easiest to access surgically.
Lateral to the muscle, got it.
Level 2 nodes are located directly behind the pectoralis minor muscle.
And a bit deeper.
And level 3 nodes are located medial to the medial border of the pectoralis minor. These are the highest nodes. They're closest to the apex of the axilla, and they're technically the most challenging to clear without risk.
And the clinical insight that comes from this classification, which level is the initial landing spot? Where does it usually show up first?
Statistically, level I nodes are the group most commonly involved in nodal metastasis. They are the, you could say, initial staging zone. However, if you see involvement of level 3 nodes, that immediately signifies a much higher tumor burden, and it carries a significantly worse prognosis.
So if that main highway to the axilla is clogged, where does the lymphatic traffic divert to? What are the crucial secondary drainage routes we need to watch for?
We must always consider drainage medially to the internal mammary nodes. These lie within the chest wall, right alongside the sternum.
Okay.
Or it can go superiorly to the supraclavicular nodes, which are just above the collarbone.
And finding it there is a big
A
deal.
very big deal. If we find involvement in the supraclavicular fossa, the disease is automatically classified as locally advanced, specifically stage 3. That dramatically escalates the management plan.
Let's talk about the support system now, the vascular and nerve supplies.
Mm.
What are the major blood vessels that are feeding this tissue?
The breast tissue has a really rich blood supply. It comes primarily from 3 major sources: the internal mammary perforators, which are branches of the internal thoracic artery, the lateral thoracic artery, and the thoracoacromial branch. This robust supply is part of what explains the high vascularity of breast tumors.
Now, for the surgical perspective, let's shift to nerve preservation. This is a huge Viva point,
Huge.
which 2 nerves are absolutely critical to identify, protect, and why. I mean, if you damage these, you create a major functional deficit.
This is a critical point in the operating room. First, you have the long thoracic nerve. Sometimes it's known as the nerve of Bell.
Nerve of Bell.
It runs down the chest wall, and it supplies the serratus anterior muscle. If you injure it, you get paralysis of that muscle, which results in the classic finding of winging of the scapula.
Ah, I've seen pictures of that. The shoulder blade just juts out.
It protrudes posteriorly, and it severely limits arm movement above the horizontal.
And that's not just a cosmetic issue, that's a severe functional impairment.
Exactly. And preserving the long thoracic nerve can be surgically challenging, especially during a level 3 dissection. Because of its location, it's quite vulnerable.
Okay, so that's nerve number 1. What's the second one?
The second critical nerve is the thoracodorsal nerve. This one supplies the latissimus dorsi muscle, the big muscle on your back.
Right.
Now, while its injury results in some back and shoulder weakness, its preservation is also critical for future planning.
Future planning. What do you mean?
The latissimus dorsi muscle often serves as the flap that's used in post-mastectomy breast reconstruction.
Ah, I see.
So by preserving that nerve, we are preserving reconstructive options for the patient, along with preserving function.
That really puts the anatomical knowledge in the context of both immediate function and long-term quality of life.
Brilliant. Okay, with the anatomy mapped out, let's move to how the disease presents clinically and the structured pathway we have to follow for diagnosis. What are the classic clinical hallmarks, the red flags that signal a potentially malignant lump?
Well, when you're describing a lump, either for documentation or during an exam, the critical adjectives are typically that it is painless, hard, irregular, and not well-defined.
Not well-defined. Right. The mass is usually fixed to the surrounding tissue, which implies infiltration. This is very different from benign masses like fibroadenomas, which are generally smooth and highly mobile. You know, they move around easily.
And I think it's important to reiterate that point about the lack of pain. If a patient comes in complaining of acute breast pain, their presentation is less likely to be a typical malignancy, right?
That's a crucial clinical distinction to make. Pain or mastalgia is rarely the presenting complaint in an early typical invasive ductal carcinoma.
So when should pain make you suspicious?
When pain is present, it raises suspicion for something that's rapidly progressing, like inflammatory carcinoma or very advanced disease where the tumor is actually invading nerves or the chest wall.
Okay. Beyond the palpable mass, what associated skin changes or nipple signs immediately raise that suspicion threshold?
We look for changes that indicate the tumor is tethering or pulling on things. Nipple retraction, for example, especially if it's new and it's fixed, is highly suspicious.
And skin dimpling.
Skin dimpling is caused by the tumor pulling on these little ligaments called Cooper's ligaments. It causes the skin to pucker, especially when the arm is raised or the breast is compressed.
Right.
In more advanced cases, you see the classic peau d'orange appearance.
Like the skin of an orange.
Exactly. It looks like orange peel skin, And it's due to extensive lymphatic blockage that leads to edema or swelling in the skin.
And regarding nipple discharge, there's one specific presentation that demands immediate action.
Yes. While many types of discharge are benign, milky or greenish, bloody nipple discharge is flagged as the most suspicious finding. It necessitates an immediate triple assessment.
Let's talk about that. Once suspicion is high, we initiate the mandatory triple assessment. This structured approach is the standard of care. Can you walk us through the 3 required components?
This is a mandatory sequence. You can't skip any pillar.
Don't miss a point.
Don't miss a point. Pillar 1 is the clinical examination. This involves thorough inspection and palpation, not just of the tumor, but also the crucial regional lymph nodes.
So the axilla and the supraclavicular fossa we just talked about.
Precisely. Pillar 2 is imaging, using the right tool for the right patient. That could be a mammogram, an ultrasound, or an MRI.
Okay.
And pillar 3 is cytology or histology. So getting a tissue sample for a definitive diagnosis and, crucially, for molecular subtyping.
Let's elaborate on imaging for a second. What guides the choice between mammography and ultrasound, particularly with age considerations?
It's a great question. For women over 40 or 50, or for screening, the mammogram is the standard. It allows us to categorize lesions using the standardized BIRA scoring system, which quantifies the level of suspicion from 1 to 5.
But it's not as good for younger women.
No. In younger women, breast tissue is often very dense, and that density can hide tumors on a mammogram, making it less effective. It just shows up as white on white.
So for younger patients,
For younger patients, or for further characterization of a lesion found on a mammogram, the ultrasound is preferred. It's excellent at distinguishing solid masses from cysts. MRI is generally reserved for specific high-risk scenarios, like screening women with very dense breasts or assessing response to treatment before surgery.
okay, so the ultimate confirmation is the tissue sample. We have 2 main ways to get that: FNAC, fine needle aspiration cytology, and core needle biopsy.
Yeah.
In modern oncology, why is the core needle biopsy so overwhelmingly preferred? This is a fundamental change in practice.
This is an absolutely essential clinical distinction today. FNAC is quick, and it can confirm malignancy, sure, but it only provides scattered individual cells.
Just a smear of cells.
Exactly. The core needle biopsy provides a cylinder of intact tissue, an actual piece of the architecture of the tumor.
And why is having that intact tissue so critical for management?
Because without it, we cannot perform the immunochemical staining that's required.
And that staining tells us.
It tells us the tumor's molecular profile. Specifically, the status of the estrogen receptor, or ER, the progesterone receptor, PR, and the human epidermal growth factor receptor 2, which we call HR2.
ER-PRHAR2.
These receptors are the therapeutic targets. Knowing the ERP2 status defines whether the patient gets hormone therapy, targeted therapy, or standard chemotherapy. A diagnosis of just cancer is almost useless without the molecular subtype to guide the treatment.
So the diagnostic step is intrinsically linked to the therapeutic strategy from the very beginning. Before we finalize that strategy, though, we have to confirm the spread. What is the mandatory pretreatment assessment needed to rule out distant metastasis?
Once malignancy is confirmed by that core biopsy, we require a full staging workup. This typically includes a CT scan of the chest, abdomen, and pelvis, often paired with a dedicated bone scan, or in many centers now, a single PT-CT scan, particularly if the disease appears aggressive or locally advanced.
And the goal is?
The goal is to ensure there are no signs of stage 4 disease before we commit to a potentially curative local treatment plan. We have to know the full extent of the battlefield.
This next section is really the linchpin of management, isn't it? The treatment strategy. Whether we operate first or use drugs first, it all hinges entirely on the clinical staging. We have to understand the definitions of early, locally advanced, and metastatic breast cancer.
Accuracy here is paramount. We use the formal TNM system, tumor, node, metastasis, but clinically we categorize it into these 3 major buckets.
So let's start with the ideal scenario. Early breast cancer, or EBC. This is stage 1 and stage 2 disease. What is the defining characteristic?
EBC means the disease is still confined to the breast tissue and the regional lymph nodes, so the axilla. And critically, it is resectable. It can be surgically removed up front.
Okay, so manageable.
Right. The tumor size is manageable, the nodes are typically not matted together, or there's only a few of them, and there's no evidence of distant spread. For EBC, surgery is the default initial local treatment option.
Okay. Now, the complexity escalates with locally advanced breast cancer, or LEBC. This is stage 3. What are the clinical criteria that bump a patient into this more serious category?
LABC means the tumor burden is so high or the local invasion is so expensive that immediate definitive surgery is either risky or just ineffective.
What does that look like?
The criteria include 1, a large tumor size, so typically T3, which is over 5 centimeters.
Okay.
2, involvement of surrounding structures. We call this T4. This is invasion of the skin, causing ulceration or extensive edema or adherence to the chest wall, so the pectoralis major muscle, or the ribs.
So it's breaking out of the breast itself.
Precisely. And the third criteria is extensive nodal disease, N2 or N3. This means matted or fixed axillary nodes or involvement of those internal mammary nodes or the supraclavicular nodes we mentioned.
And there's a unique type of LABC that is defined by its clinical presentation, regardless of the tumor size.
Correct. Inflammatory breast cancer. It always falls under LABC, specifically stage 5, because its hallmark is dermal lymphatic invasion.
Right, the skin involvement.
And that signifies widespread local lymphatic dissemination, making immediate surgery futile and necessitating systemic pretreatment.
Finally, metastatic breast cancer, MBC, stage 4.
Stage 4 is defined very simply by the presence of distant metastasis. The cancer cells have traveled beyond the breast, the axilla, and the chest wall.
And the most common sites we need to monitor during that initial staging workup.
We are vigilant for spread to the bone, the lung, the liver, and less commonly but more severely, the brain.
And once MBC is diagnosed,
Once MBC is diagnosed, the therapeutic goal shifts entirely. You move away from a curative local treatment toward palliation and long-term systemic control of the disease.
now that we have that staging framework, let's walk through the strategic pathways. We start with early breast cancer, EBC. For these stage I and II patients, what are the two equivalent primary local treatment options?
This is a core concept that every clinician, every student must know. The two options, breast conservation surgery plus radiation, or BCS plus RT, and modified radical mastectomy, MRM, are considered equivalent in terms of overall survival for most EBC patients.
Let's break down option 1, BCS. What does it involve, and what must absolutely accompany it?
So BCS involves a lumpectomy. That's removing the tumor with a clear surgical margin of healthy tissue around it.
Okay.
And it also involves axillary staging, which is typically a sentinel lymph node biopsy, or SLNB.
And the crucial component is?
The crucial component is that BCS must be followed by mandatory post-operative radiotherapy.
Always.
Always. The radiation is required to sterilize the remaining breast tissue and reduce the rate of local recurrence, which historically was much higher after lumpectomy alone.
But I have to challenge that point. If the surgeon removes the lump with a clear margin, why is radiation still mandatory? Doesn't that seem like overkill?
That's a great question, and it speaks to the microscopic nature of cancer. Even with clear margins, say 1 millimeter of normal tissue surrounding the tumor, the risk of residual microscopic disease scattered throughout the rest of the breast tissue, maybe even far away from the surgical site, is just too high.
So you're cleaning up what you can't see.
Exactly. The radiation is essentially required to bring the local recurrence rate down to a level that is equivalent to that of a full mastectomy. It's the radiation component that makes the two surgical approaches equivalent in outcome.
That clarifies the necessary partnership between surgery and radiation in BCS. So MRM, option 2, involves removing the entire breast. When is MRM specifically chosen over BCS?
MRM is chosen when BCS is deemed unsuitable or contraindicated. This might be due to a large tumor-to-breast size ratio, where the lumpectomy would leave a poor cosmetic result, or, crucially, if the patient has a contraindication to radiation.
Can you elaborate on the contraindications to BCS? There's a vital distinction here that's often stressed in surgical exams.
Yes. The critical contraindications include 1, multicentric disease.
Okay, what's that?
That's the presence of 2 or more separate tumors located in different quadrants of the breast. This is distinct from multifocal disease, where you have multiple tumors, but they're all in the same quadrant.
So location matters.
Very much so. Multifocal disease can sometimes be treated with BCS, but multicentric disease requires an MRM.
What else?
The second is an inability to receive radiation. This could be due to prior therapeutic radiation to the chest wall, or existing conditions like active connective tissue disorders, say scleroderma, that make the patient very sensitive to radiation. And third, of course, is pregnancy. Radiation exposure during pregnancy is a clear risk.
Great, let's talk prognosis again. We established earlier that nodal status is key. Let's dissect why the source highlights nodal status as the single most important prognostic factor, overriding even tumor size or grade.
It's the evidence of systemic capability. A tumor confined to the breast, a T1 or T2, is still a localized issue. It's manageable with local therapy. But once that cancer has established itself in the axillary lymphatics, even if it's just microscopic, it has definitively accessed the body's main highway system.
Head of the escape route.
It has an escape route. And that means the quantifiable risk of distant systemic recurrence in the lung, bone, or liver jumps significantly. Nodal status is the strongest indicator of who needs aggressive systemic therapy to prevent death from distant spread.
So post-surgery, the decision-making for subsequent systemic therapy is intense. What specific factors from that core biopsy guide that decision?
The postoperative decision is complex, but it absolutely relies on the 4 pillars we identified in the core biopsy.
Which are?
The ERPRE-CHAR2 receptor status, the tumor grade, which speaks to cellular aggressiveness, the tumor size, and most importantly, the nodal involvement.
Can you give an example?
Sure. A small but highly aggressive triple-negative tumor with negative nodes might still receive chemotherapy, whereas a large but low-grade ER-positive tumor with negative nodes might skip chemotherapy and only receive hormone therapy. It's all about tailoring the treatment to the biology.
Okay, moving to locally advanced breast cancer, LABC, stage 3. Here, the initial strategy flips entirely. What is the rule for LABC management?
The rule is unwavering. For LABC, you always begin with neoadjuvant therapy, or NAZCT.
Drugs first.
Drugs first. Usually chemotherapy or, if appropriate, targeted therapy. Immediate surgery is contraindicated because the local tumor burden is too high, and there's a very high likelihood of pre-existing systemic disease.
What are the 2 primary strategic purposes of delivering therapy before?
Systemic. First, the local purpose is downstaging.
So shrinking it.
Exactly. To shrink the primary tumor and the associated matted lymph nodes, converting an inoperable tumor, like one fixed to the chest wall, into an operable one, and potentially it could allow the patient to become a candidate for BCS instead of a mandatory MRM.
And the systemic purpose.
The systemic purpose is that it's an in vivo test.
A test in the body.
Right. It allows you to treat micrometastatic disease early and at the same time gauge the tumor sensitivity to the drugs you're using.
That second point is particularly fascinating. How does the response to NAZCT become a prognostic indicator itself?
It allows us to monitor for a pathological complete response, or PCR. Meaning that at the time of surgery, no viable invasive tumor cells are found in the breast or the lymph nodes.
Wow.
Achieving PCR is a massive prognostic victory, particularly for the more aggressive subtypes like triple-negative and HER2 positive breast cancer. For these aggressive subtypes, achieving PCR is strongly correlated with excellent long-term survival.
And if they don't get a PCR?
If they don't, we know we need to intensify or maybe even change their subsequent therapy.
So NAZCT acts as both a therapeutic and a diagnostic tool. After successful NAZCT, what's the sequence?
Then we proceed to definitive surgery, either BCS or MRM, followed by postoperative radiotherapy and then long-term systemic therapy.
Okay.
The decision between BCS and MRM post-NAZCT depends entirely on the residual tumor burden.
We have to pause again for that critical exception. Inflammatory breast cancer, stage I of BEB. What is the mandatory surgical approach, even after NAZCT?
Even if the tumor shrinks dramatically after NAZCT, inflammatory breast cancer requires a mandatory modified radical mastectomy.
No exceptions.
No exceptions. BCS remains absolutely contraindicated because the risk of local recurrence throughout the skin and the dermal lymphatics is exceptionally high with this subtype.
Finally, metastatic breast cancer, MBC, stage 4. The goals fundamentally shift here.
They do. The therapeutic goal is strictly palliative.
Right.
The goal is to prolong survival, control symptoms, and preserve the quality of life. The management is heavily weighted towards systemic therapy because the disease is inherently systemic.
So does surgery ever have a primary role in stage 4 disease?
The clinical pearl here is very clear. In the setting of widespread metastasis, local surgery on the primary breast tumor generally does not improve overall survival.
It doesn't help people live longer.
It does not. Surgery is reserved only for managing local complications that are causing distress. Things like severe bleeding, a painful ulceration, which we call fungation, or maybe to stabilize a fracture caused by a bone metastasis. Local control, not cure, is the aim.
And supportive care in this setting must be highly specialized.
Absolutely. We use agents like bisphosphonates or denosumab to manage bone metastases and reduce skeletal-related events like pathological fractures. For distressing symptoms, targeted palliative radiotherapy is crucial, often combined with steroids for brain metastases to reduce swelling and symptoms.
The era of precision medicine means that systemic therapy is now tailored specifically to the patient's molecular profile. Let's look at the cornerstone of drug treatment, starting with standard chemotherapy regimens.
The standard backbone regimen often involves sequential delivery to maximize efficacy and minimize toxicity. The classic chemotherapy agents include the anthracyclines like adriamycin and cyclophosphamide, followed by taxanes, so AC then T.
AC then T.
Right. The sequence is important. We often give the dose-dense agents first, followed by the agents that target the microtubule network later.
Okay, next, for the tumors that rely on sex hormones, the ERPR positive subtypes, we use endocrine therapy. And the choice here is driven entirely by menopausal status, which is a key clinical divider.
This distinction is crucial because it governs the primary source of estrogen in the body.
Okay, so premenopausal women.
For premenopausal women, the ovaries are the primary source of circulating estrogen. Therefore, the standard agent is tamoxifen, which acts by selectively blocking the estrogen receptor on the cancer cells.
And for postmenopausal women.
For postmenopausal women, the ovaries are quiescent, they're not working anymore. The primary source of estrogen shifts to peripheral fat tissue, and it's produced there by an enzyme called aromatase.
So once the ovaries stop producing estrogen, what's the therapeutic logic? How do you attack that?
The logic is to starve the tumor of its fuel by blocking that peripheral conversion process. So the standard agents are aromatase inhibitors, or AIs, like letrozole, anastrozole, or exemestane.
I see.
Blocking aromatase dramatically reduces circulating estrogen, which is highly effective in this patient group. Giving tamoxifen to a postmenopausal woman is often less effective than giving an AI, and vice versa.
Now, let's discuss the revolution brought by targeted therapy, specifically for the HER2 positive tumors. These are often aggressive, but now highly treatable.
Yes. Approximately 15 to 20% of breast cancers are HER2 positive. This means they overexpress the human epidermal growth factor receptor 2.
And these tumors are?
They are highly responsive to agents that specifically block this receptor signaling pathway. The classic example is trastuzumab, brand name Herceptin. We now often combine this with other agents like pertuzumab, which targets HER2 in a different way, or we use antibody-drug conjugates like TDM1 for residual disease.
The effectiveness of trastuzumab is phenomenal, but it comes with a known safety profile issue. What is the crucial safety check required before and during treatment?
The key safety alert, and this is a don't miss point, is the risk of cardiotoxicity.
Heart damage.
Yes. Trastuzumab can cause an asymptomatic decline in the left ventricular ejection fraction, potentially leading to symptomatic heart failure.
So what do you do about that?
Because of this, every patient starting trastuzumab must have a baseline 2D echo test to assess their heart function, and this monitoring must continue throughout the entire treatment course.
So you're making sure you're not solving one problem, the cancer, by creating another one, heart failure.
Precisely.
Let's pull back to surgery and discuss the modern standard for axillary management, sentinel lymph node biopsy, or SLNB. How has this technique changed breast surgery?
SLNB is a massive quality of life advancement. Instead of routinely removing all the axillary lymph nodes, which is an axillary clearance and leads to the complication of lymphedema.
Arm swelling.
Right, the chronic, painful arm swelling. SLNB identifies and removes only the first draining node, the sentinel node, using a tracer like blue dye or a radioactive isotope.
And if that node is clean?
If that sentinel node is negative for cancer cells, we can safely conclude the rest of the axil is clear, and we spare the patient the morbidity of a full dissection.
When is SLNB appropriate, and what is the critical caveat?
SLNB is used only in a clinically node-negative axilla. So on exam, you don't feel any suspicious nodes.
Okay.
If the nodes are already palpable, matted, or confirmed positive preoperatively by a biopsy, the sentinel node procedure is bypassed and a full axillary clearance is required.
And there was a big trial, the ECOSOG Z0011 trial, that redefined our approach even for women with positive sentinel nodes in EBC. Can you briefly touch on that implication?
That trial was revolutionary. Historically, if the sentinel node was positive, you automatically did a full axillary clearance. Z0001 demonstrated that for women with T1 or T2 tumors undergoing BCS who have just 1 or 2 positive sentinel nodes and are receiving whole breast radiation.
A very specific group.
A very specific group. For them, a full axillary clearance provides no survival benefit and can often be omitted. This decision further reduces the risk of long-term lymphedema.
Finally, we must return to the concept of supportive therapy. Managing this disease is not just about the technical removal of tissue, it's about managing the patient's entire journey.
This is the holistic aspect of care. It includes mandatory elements like physiotherapy immediately post-surgery to maintain shoulder and arm mobility and prevent stiffness. Crucial patient education on lymphedema prevention is necessary, especially after any axillary intervention. We must integrate psychological counseling for the intense mental strain, robust pain management, and comprehensive discussions about reconstruction options to restore body image.
And
of course, specialized palliative care for symptom management in the advanced setting.
these supportive measures are fundamental to delivering on that initial promise we talked about. Restoring a life, not just removing a tumor. We have covered immense ground, moving from anatomical boundaries all the way to molecular targets. Let's run a rapid synthesis of the core clinical facts, the golden points that connect anatomy, pathology, and management.
This is the distillation, the essential facts you have to internalize.
Okay, starting with geography. Anatomically, where does breast cancer most commonly originate?
The upper outer quadrant. This reflects the greater volume of glandular tissue that extends into the tail of Spence.
Let's contrast the postoperative radiation requirements for the two major surgical procedures. Does a modified radical mastectomy always require radiotherapy?
No, an MRM does not automatically require radiotherapy. It is only added if there are high-risk factors identified in the pathology report,
Such as?
such as a very large tumor size, close or positive surgical margins, or extensive nodal involvement, specifically 4 or more positive axillary lymph nodes.
What is the unique histological feature that defines inflammatory breast cancer?
Dermal lymphatic invasion. You see tumor cells plugging the lymphatic channels of the skin itself, which is what causes that classic presentation of redness and edema that can mimic an infection.
Confirm one last time. Why is core biopsy superior to FNEC?
The core biopsy provides intact tissue that is required for the essential molecular subtyping, ER, PR, and HER2 status, and that dictates the entire systemic treatment plan.
Let's discuss molecular prognosis. We now know that breast cancer is not one disease. Which molecular subtype generally carries the most favorable prognosis?
That would be the luminal A subtype. These are typically highly ER-PR positive, HER2 negative, and have a low proliferation rate, what we call a low Ki-67.
And that makes them.
That makes them highly responsive to long-term hormone therapy.
And conversely, which subtype has the lowest pathological complete response rate to NACT and the worst overall prognosis?
The triple negative or basal-like subtype, being negative for ER, PR, and HER2, they are dependent solely on chemotherapy and are often characterized by being high-grade and having a rapid recurrence.
Finally, let's synthesize the surgical decision. What is the core conclusion that revolutionized surgical practice regarding early disease?
That breast conservation surgery plus mandatory radiotherapy is equivalent to modified radical mastectomy in terms of overall survival for most patients with early breast cancer. This is the bedrock of modern surgical management.
We have completed this incredibly detailed deep dive into the surgical and systemic management of carcinoma breast. We've established the critical necessity of a structured diagnosis, that triple assessment, and the absolute requirement for meticulous staging to tailor the treatment path.
And the necessity of multimodal treatment is so clear. It's combining local therapy, so surgery and radiation, with systemic therapy, endocrine, chemo, targeted therapy, all dictated by that individual tumor's profile.
The ERPR2 status.
Exactly. We also recognize that every decision from axillary clearance to reconstruction impacts the patient's life long after the tumor itself is gone.
And as we close, we return to that guiding principle we started with. The source material reminds us that with such complex pathology, a tailored approach is everything. It says no two breast cancers are the same, but every breast cancer must be approached with reason, precision, and compassion.
And that precision is what is driving research forward. We saw how the success of neoadjuvant therapy allows for downstaging, and how crucial achieving a pathological complete response is, especially for those aggressive subtypes.
So let's leave you with a provocative thought that builds directly on the material we covered, especially the growing success of systemic therapies and the movement toward de-escalating surgery where possible.
Right. If neoadjuvant chemotherapy and targeted therapy regimens continue to improve, pushing that pathological complete response rate higher and higher, especially in those aggressive HER2 positive and triple negative diseases, The question becomes,
Could there be a future where the current standard of mandatory surgery, even in cases with minimal residual disease following NICET, is challenged even further?
exactly.
Could systemic treatment eventually negate the need for the knife entirely in certain highly responsive molecular subtypes, allowing local control to be maintained solely through precision radiotherapy and long-term drug regimens?
It's a compelling line of research, and it continues to define the future of breast cancer treatment. Thank you for joining us for this deep dive.